I have the pleasure of introducing Dr. Wiliam Pewen. Dr. Wiliam Pewen holds both a doctorate in infectious diseases and microbiology and an MPH in epidemiology from the University of Pittsburgh, where he worked in both vaccine development and the use of antiviral drugs. As a 2003 Congressional Fellow of the American Society for Microbiology, he became engaged in the issues of biosecurity and pandemic preparedness. He subsequently served as a senior health policy advisor to U.S. Senator Olympia Snowe from 2010. For the past year, he has been engaged with the Ministry of Health of Ukraine in outbreak prevention and mitigation efforts. So at this time, I would like to turn the floor over to Dr. Pewen.
I came to the crisis I'm going to discuss today with what many would describe as a somewhat multifaceted background. That includes doctoral study of infectious disease at the University of Pittsburgh, an MPH in epidemiology, and experience in both vaccine development and the study of therapeutics. There's an almost 7-year stint as a U.S. Senate advisor in which one certainly gains not just knowledge of how policy gets implemented, but the art of the possible. There are others doing government contracting and consulting, time spent teaching health professions, building research laboratories, and overseeing studies. Having begun my career in the Veterans Administration, in the midst of the HIV epidemic in the 1980s, and most recently being engaged in COVID response, I've said a lot in the last few years, this isn't my first rodeo. However, this was my first war. My engagement in Ukraine began several years ago when in early 2020, I was first contracted on a project for the Defense Threat Reduction Agency. The onset of the COVID pandemic first resulted in modification of the project, then its suspension. Many of my colleagues had also been involved in the project, and we grew to see its suspension as tragic, as recent engagement in Ukraine would have positioned all of us to better respond last year. Within a week of the February 22nd invasion, I was meeting with colleagues as we recognized that Ukraine's infectious disease burden would escalate with expanding conflict. We began discussing how we might partner to assist. With none of us having been recently on the ground in Ukraine, it was clear that at least one of us should visit the country to assess conditions and ways in which we could engage. I offered to travel and gain some first-hand knowledge of conditions. I planned about a week in country in June and didn't return until December. It's helpful to understand the nature of this conflict. It's a mix of both high-tech and retrograde ground conflict that's been reliant on both the aid of other nations and a huge international volunteer effort. I sometimes term this the crowdsourced war. Ukraine's reliance on volunteers from the US, UK, and other nations is simultaneously inspiring and worrisome, as one sees both sacrifice and a high level of chaos. The abundant caution which prompted the initial closure of our embassy in Kyiv also minimized US presence in the country, and that has certainly impacted both our understanding of the conflict and the effectiveness of our response. It's key to understand how infection contributes to war casualties. Throughout our history through the First World War, infectious disease has been responsible for far more casualties than trauma from combat. Most of us are now familiar with how the pandemic influenza swept the world beginning in World War I. Yet by the Second World War, the introduction of antibiotics and wide adoption of immunization vastly reduced casualties from infection. Tragically, in our modern era, both those advances are being eroded. The misuse of antibiotics is contributing to resistance in pathogens, and declining immunization is resulting in outbreaks of infections that were once becoming rare. The Russian invasion began in just this climate. Conditions in Ukraine now combine with Russian aggression to threaten a perfect storm. While Ukraine has made substantial strides in combating tuberculosis, HIV, and hepatitis, its combined rates of those diseases remain exceptional among European nations. Other infectious diseases, ranging from measles to rabies, constitute greater threats than in the U.S. As a middle-income country, Ukraine's health system is still continuing to develop. Its immunization rates have been markedly lower than other European countries. Combined with extensive antimicrobial resistance, Ukraine's susceptibility to epidemic disease remains high. Russia knows this. It need not use a bioweapon to inflict disease on the Ukrainian people. It knows that in targeting the civilian population and critical infrastructure and can simply induce epidemic disease by exploiting the endemic pathogens. Russia has damaged or destroyed over 1,100 health facilities. Most Americans have seen but a small slice of the devastation on housing, which displaced millions of Ukrainians from their homes. Water supplies have been contaminated or destroyed, sanitation compromised, and power systems disrupted. This photograph is but one I've taken depicting the destruction. Here, that of a hospital in Irpin. There and in nearby Bucha, I toured hospitals, schools, churches, housing, and a massive shopping complex, all devastated by Russian forces. This is a war which deliberately targets the civilian population. Thousands of civilians have died and millions have been displaced. The consequences of the conditions which I have described have disrupted immunization, impaired healthcare, and placed individuals into crowded conditions in which the escalation of infectious disease comes as no surprise. A 59% escalation in tuberculosis in the past year may be but a tip of the iceberg. Three key threats confront us. The first of these is the most obvious. That is, that illness, disability, and deaths associated with infectious epidemic disease. Ukraine's seen these before, ranging from the rapidly expanding HIV epidemic of the 1990s to a measles epidemic which ended just 4 years ago, after spawning over 115,000 cases in Ukraine and thousands more in Europe. Wartime conditions should be expected to generate epidemics of even greater magnitude. Pathogens don't respect borders, so one can expect that EU and NATO nations are likely to be impacted by such epidemics. Given our history with HIV, Ebola, and COVID, it would be naive to presume that such epidemic disease would not only impact other nations, but it could also impact their support for Ukraine. The toll of disease could expand and even further extend the duration of the war, as well as its outcome. Third, it's clear that both post-war recovery and future economic development would be impaired by epidemic disease, as would Ukraine's advancement to fully EU membership. Finally, while I always acknowledge the priority of the successful conclusion of this war and the critical need to triage our health response, I'm reminded we must be able to multitask if we are to succeed in such a critical endeavor as preserving a nation. We must be able to walk and chew gum at the same time. That's a good analogy, in that the major task of prevailing war must be accompanied by a host of lesser tasks, including preserving the public health. That is, for example, precisely why the Allies had success in post-World War II recovery. So what is most important to combat the threats I've described? One begins by doing some assessment and listening to those in need. First, there are areas in which technical and policy support can be helpful. Such needs are neither expensive nor complex to meet. Second, it's critical that effective response to outbreaks is assured, and that relies on the availability of both diagnostics and therapeutics, as well as some mobile capacity to deliver these in the wartime environment. While response is critical, it's clear that the prevention of outbreaks is central to any sustainable strategy to reduce infectious disease. Thus, resources to improve immunization and raise vaccine coverage are foundational to reducing the burden of infectious disease. In that regard, it's helpful to examine Ukraine's current national vaccination schedule. It's one which is quite different from our own. This schedule is limited, effective, and finite. At its core are three products which my colleagues wish we could administer broadly and quickly: DPT, MMR, and polio vaccine. In addition, with substantial tuberculosis prevalence, newborns also receive BCG vaccine, and hepatitis B and HIV vaccines are also employed. One will note the schedule is a lot less extensive than that in the US or the EU. I'll note that COVID vaccination had reached about 35% of the public at the time of my arrival in June last year. In addition, a comparable proportion of the public had experienced COVID infection, somewhere between 35 and 40%. With COVID mortality reaching over 110,000 late in 2022, Ukraine's COVID mortality rate appears comparable to that of the US. The introduction of COVID immunization is illustrative of the challenges in introducing new vaccines. Whereas most vaccines currently used in Ukraine involve a limited set of administrations which confer long-term immunity to serious disease, new vaccine introductions can pose a more complicated value proposition. For example, COVID immunization presents significant side effects to a substantial minority of the recipients, appears to require frequent boosting to address new strains, and may not protect well from the development of symptomatic disease, but does reduce hospitalization and mortality. However, considering the relationship of age and comorbidities with COVID outcomes, success in achieving broad immunization of the population faces significant challenges. Such was already evident in Ukraine's experience with influenza immunization, in which only approximately 170,000 annual vaccinations are performed. This leads us to look at trends in immunization rates and the level of protection in the population. At the time Ukraine gained its independence, immunization rates for its very limited vaccine schedule were exceptionally high, as was the case throughout the states of the former Soviet Union. Introductions of new vaccines post-independence were also well received. Then in 2008, you'll note a critical inflection point. This coincides with several events. First was the death of a boy after receiving MMR vaccine. While his death was due to bacterial meningitis, anti-vaccine advocates claimed the vaccine is the cause. This was also at a point at which Ukraine had ceased its purchase of Russian vaccine. Russian anti-vax messaging was active. Immunization rates declined by almost 50% in a single year, and Ukraine struggled to restore performance. Just as some level of recovery was being realized, the Russian invasion of Crimea in 2014 created economic shocks, a delay in vaccine ordering, and a persistent suppression of immunization rates followed. Rates only began to rebound as a massive measles epidemic occurred beginning in 2017. By 2019, that epidemic began to wane and immunization rates rebounded, but remained below the pre-2008 levels. Essentially, what we see in this graph is a combination of so many factors that impede immunization: anti-vaccine sentiment, economic and policy obstacles, technical problems, and conflict. Sometimes factors synergized. Lapses in vaccine cold chain and handling may have combined with alleged poor efficacy to explain why approximately 20,000 of the 115,000 measles cases which occurred during the epidemic were in those of an age in which vaccination had been nearly universal. Most of the potential impediments to successful immunization were clearly evident, and with demographic statistical data, we can produce some reasonable estimates of the resulting population risk. While the previous graph was impressive to many who first saw it, this table provides some quantification of the level of deficits we have in current coverage, as well as where they lie. If one examines immunization rates reported over the past 3 decades, and you weight within a group according to current population by age, it's possible to calculate some reasonable estimates of coverage. Thus, we can roughly estimate that approximately 56% of those under 30 have completed immunization for hepatitis B. That's in the left-hand column, the 1992 to 2021 cohorts. This does not account for some catch-up immunizations, of course, but only one substantial remediation was reported, and that was of about 1.5 million doses of MMR during the 2017 to 2019 measles epidemic. Even that remediation proves minor when we consider the level of deficiency. Especially keep in mind, WHO target for measles is greater than 95% coverage. The most striking deficit we see is in the yellow, bright yellow highlighted column, covering the decade from 2009 to 2018. Overall immunization rates average 59%. However, the use of the single-dose BCG vaccine administered to newborns elevates that. If that's excluded, the mean rate of immunization begins to approach just half of the population targeted. This analysis demonstrates a remarkable concentration of immune deficit within a cohort of children currently under 15 years of age. So we add in those children from 2019 to 2021 for the sake of convenience, come up with a target group of 5.2 million, those cohorts. While the precise calculation of the number of children impacted is difficult, a minimum can be projected. If the vaccine with the lowest immunization rate also encompassed all of the missed immunizations for all the other vaccines, that's an inconceivably small probability, of course, over 2.7 million children would be impacted in that 2009 to 2021 period. It appears far more plausible that the actual number of children impacted likely ranges between 3 and 4 million. It's also critical to note that the relative contributions which improvements in scheduled immunizations can make are limited in terms of reducing the pool of risk. Birth cohorts in Ukraine have declined approximately 50% in size since independence, reaching just under 271,000 in 2021. Thus, even in the inconceivable possibility that all immunization deficiencies segregated in just 2.7 million children in that under 15 age group, the risk pool in this age group exceeds 10 times the size of an entire birth cohort. What this means is clear. While improvement of scheduled immunization is necessary, it will not be sufficient to substantially affect risk in the population. In fact, one can conceive of future reports of improved scheduled immunization rates, which are then followed by infectious epidemics, which consequently then erode confidence in immunization, i.e., not only would Ukraine suffer epidemic disease, but vaccine hesitancy could be further entrenched. This slide details the proposal for funding of the 3 objectives outlined earlier for outbreak prevention and mitigation. Efforts were made beginning in July last year to obtain some critical funding to ensure both response capability, things like diagnostic tests and therapeutics, as well as prevention via support for immunization, and in particular by targeted catch-up immunization. These efforts recognize the significant lead time required to assure the acquisition of the vaccines which would be needed. The proposal was designed so as to provide advance appropriation for the full 4-year term of the intervention. In particular, the immunization plan utilizes a maintenance of effort provision designed to complement rather than replace the current efforts of both the government of Ukraine and UNICEF to sustain scheduled immunization, mostly occurring at those children under 2 years of age. This expenditure proposed, covering 4 years, represents less than 0.1% of the total value of U.S. assistance extended thus far to Ukraine. USAID funding for Ukraine assistance from the December omnibus spending bill has been reported at $1.4 billion. None of this was expressly appropriated to purpose or itemized in the omnibus. Very little is flowing to health. While a specific aid commitment wasn't realized in 2023, the Minister of Health cited the critical need to prioritize immunization to prevent epidemic disease. In addition, the report of 2022's scheduled immunization by Deputy Minister Kuzin, in the second statement here, notes this effect of conflict in reducing the effective rates last year. Without substantial U.S. assistance, Ukraine is relying now on its own resources along with assistance from UNICEF to sustain scheduled immunization. Notably, in the third panel, the UN, through the WHO, chose an appropriate theme for World Immunization Week in 2023, calling it the Big Catch-Up. Tragically, while addressing a pandemic with vaccine, routine immunization to prevent epidemic disease has faltered. Childhood immunization has declined, and the WHO campaign now specifically targets 20 nations of focus, where immunization rates are currently especially low. Those nations do not include Ukraine. Its long trough of minimal vaccination, 9 years of war, and the displacement of millions may not have been considered. So now the question is logically, where do we go from here? There simply isn't vaccine to conduct the sort of catch-up required for risk mitigation. Due to the failure of the U.S. to fund vaccine acquisition last year and growing worldwide demand, Ukraine's largely locked out of the market. The proposal which we discussed in November was described by one U.S. official as the Big Bang. That sort of rapid response has been attempted before, and quite successfully. In a 1947 smallpox outbreak in New York City, well over 2.7 million were immunized in a month. That's comparable with the number of Ukrainian children we've identified in critical need of immunization. Much of the vaccine was not on hand, and yet resources were still marshaled, rapid immunization was conducted, and demand for vaccination was high. An epidemic was averted. Yes, this was in a post-World War II environment. It was a different time. The proposal we considered last year was no big bang. It was a nearly 4-year effort, one which recognized vaccine hesitancy, social dysfunction of our time, and the just-in-time nature of supply chains, as well as the stresses which conflict is imposing. It was also a proposal which used primary care to effectively and efficiently deliver immunization in a sustainable way. Yet that does little to benefit contractors or anyone who follows the outrageous escalation in the pricing of replacement arms as high as 20-fold over 20 years. We all understand the Washington axiom, follow the money. Immunization is not profitable. It is effective for improving health. Facing the prospect that a U.S. commitment to catch-up immunization may not materialize, Ukraine formulated a nearly decade-long effort to remediate the problem. This year, that involved obtaining about 274,000 MMR doses to perform some catch-up immunizations to help reduce the risk of another measles epidemic. That's maybe about 10% of what will ultimately be needed. Those doses have proven unobtainable from manufacturers. The hope is we may obtain some surplus donations from U.S. and Canadian health systems. This is where we are and what we've learned after years of a global pandemic. At best, we could see funding somehow materialize, but that won't produce relief until next year in terms of supply issues. That will be 2 years since the invasion, and then we must begin recovery and hope we don't see more epidemic disease breaking out in the interim. I had an interesting inquiry last week. A recruiter wanted to know my interest in administrating a major biocontainment research lab. I've worked in such an environment. I've built laboratory infrastructure and conducted that research. But I declined, thinking of the current situation we are facing. Of what use are either vaccines or drugs if they sit on the shelf? If a preventive or a cure is inaccessible, it becomes irrelevant. Overcoming that is our challenge.